Us today, Dr. Nilanchal from Institute of Neurosciences, Kolkata, and Dr. Bibu Kalyani, ma'am. She will be chairing the session. Over to you, ma'am.
Okay, good evening to all and greetings from the Neurosciences, Kolkata. We are really privileged to be a part of this program, the Neuro class. And thanks to Dr. Julfikar and all the organizers of this program. Thank you very much. So we have today a very important topic to discuss, that is sepsis in neuro-intensive care unit. And as we know that acute CNS injury, whether it is trauma or it is post-surgery or it is vascular insult or degenerative diseases of the nervous system, they all trigger to the inflammatory response and thereby cause the immunomodulation and the secondary injury. So many factors are there for sepsis or infection in the neurointensive care, starting from age, genetic factors, predisposition, degree of and mechanism of injury, systemic injury in polytrauma cases, and therapeutic interventions which land up with nosocomial infections. Like we have to monitor the CBP, the arterial blood pressure, arterial, then intubation, ventilation, all these things. And many patients are land up with VAP, and post-surgery we land up with surgical site infection and also the ventriculitis, meningitis, all these things, as we all know. And thereby also the patients are ventilated for a long, prolonged period, and thereby land up with many aspiration pneumonitis, VAP, and all these things. So these are again healthcare associated infections. So both healthcare and mainly the patient may come with infection also. With meningitis and ventriculitis, encephalitis, these patients come to the Neuro Icu. So today we are going to discuss all these things, and our presenter, as Dr. Julfikar already said, Chakraborty, who is MP in anesthesia, and he has done his postdoctoral critical care fellowship from the SGPGI, and he has done his European diploma in critical care, and clinical he has been specialist, and she will moderate the session. She has also done her neurocritical care. She is a teacher, trainer of the training in neurocritical care. And so without wasting time, I'll request Nilanchal to go ahead with his presentation. Nilanchal, please.
Thank you, ma'am. Good evening, and wish you a happy new year to all. So it start with a new year with a very old topic, which is sepsis in neuro ICU, which we face every day and day-to-day basis. So, sorry, I cannot change the slide. So, what is sepsis? It is defined as a life-threatening organ dysfunction caused by the dysregulation of the host response to infection. And in clinical criteria, the documentation of infection with acute increase in the 2 or more SOFA point, that is a sequential organ dysfunction assessment scoring point, we call it sepsis. So starting from 2004 to till now in 2021, the guideline makers started to define sepsis for making a proper study, training, and improve in the outcome. They initially started with the SARS score, more than 2 SARS scores with or presumed infectious process. And when there is an organ dysfunction, they started to call it severe sepsis. And finally, when there is a drop in the blood pressure despite a fluid bolus, they called it septic shock. But then they gradually upgraded to more refining the definition. And now we have only sepsis and septic shock. Why it is different? Because the hospital mortality increases from 10% to more than 40% with shock, especially septic shock. When along with infection, there is requirement of vasopressors because the lactates are more, which is more than 2 millimole per liter. So especially in these cases, in every ICU, especially of course in our neuro ICU, we have to be very prompt in defining or identifying and then act accordingly. But defining sepsis, which starts with different SARS criteria and along with some fever, is very difficult in neuro ICU because fever may be present in the first week of hospitalization, more than 87% of the patients. And it may be 33% to 50% cases, it may be non-infectious. It may be just central fever. And if the ICU stay is longer, the infection chances increases. And most of our patients who require any kind of neuro interventions, 40% of them has some kind of infection in any part of the body. But why it is so? Because these patients in neurocritical care are prone for infections. There is different suppressions in immunomodulations, different inflammatory cytokine increase, and that is only internal, but externally we see the long stays in ICU compared to any other ICU, number of catheters, whether it's a urinary catheter or it's a ventricular catheter or just a tracheostomy, and patients are there for months. When they're there for months, they receive multiple antibiotics. So ultimately they're colonized with multi-drug resistant organisms and chances of infection goes high. Along with that, specific kind of patients in neuro ICU, like patient in stroke or patient with neuromuscular diseases, they have problems with dysphagia, which causes them more prone for aspiration pneumonia. So these infections are specific for our neuro ICU, and this causes them for more chances of sepsis. But apart from sepsis, whether only fever in neuro ICU is detrimental? Yes, it is, because if you see in some meta-analysis that and systemic reviews, the dotted line is all the parameters which analyze different sepsis marker and 38 to 38.3 degrees Celsius taken as a fever cutoff. You can see that the mortality, the Barthel index for ultimate outcome, the Glasgow outcome score, Canadian stroke score, length of stay and hospital stay increases when the patient has a fever, especially if they have a fever even after 7 days. So if you see in this table, you can see the relative risk of all these things, starting from mortality to hospital length of stay, ultimately increasing the hospital burden, increases with the fever. Now, of course, the duration of fever. So itself, fever is harmful for neuro ICU. It increases the cerebral edema, especially in those patients where perfusion is compromised. So, and per se sepsis is harmful, and of course, we cannot actually eliminate them, but it has to be treated in a prompt manner. So how to identify that? Apart from the sepsis definitions, that is from sepsis 1 to sepsis 3, there are different parameters. But along with that, all the parameters, even Q, SOFA, and sepsis 3 definitions are not too sensitive marker for defining sepsis. So this is a systemic review which analyze different rapid emergency trial system, compare the quick SOFA and SARS 2 definition to identify sepsis earlier. They red flagged, orange flagged, yellow flagged, and green flagged, and compared them with the quick SOFA score. And what they found is that the quick SOFA score has very low sensitivity. Only 0.32 is the sensitivity of quick SOFA score in detecting the sepsis. So when we are trying to identify a patient in neuro ICU or any ICU, and we need to think whether we need to give an antibiotic or not, quick SOFA score especially is not very helpful, especially in neuro ICU, where itself the patient has a low GCS which is less than 15. So still the SARS more than 2 criteria holds a good sensitivity, even though it's just only 0.74 for detecting the patient's. So other than the clinical parameters, can we look for other markers in sepsis? Yes, there are different parameters we use, like the CRP, and the procalcitonin, when they used combined together, it has been found that CRP of more than 50 or procalcitonin of 1.1 had relatively good sensitivity parameters, like around 90% sensitivity to detect a sepsis. So along with clinical and also these parameters helps us to detect sepsis. But in this, especially Neuro Icu and long stays, many of these parameters are high. So we need to think of other causes of fever in Neuro ICU when the fever is happening very early in the phase, maybe within 3 days. And different studies have looked after different multivariate analysis to find out how to negate central fever from sepsis, because sometimes we overtreat them. And if you do not actually find the proper source of sepsis and give an inappropriate antibiotic, mortality increases. So in analysis, they have actually tried to look for central fever, which is a diagnosis of exclusion, by looking out different sources of sepsis, like the chest, whether there is interventricular blood, if the fever is more than 72 hours, whether there was a blood transfusion or not. And they have come out with the algorithm to find central fever from sepsis. If there is no cultures positive, there is no interventricular blood, and the fever is within 72 hours, we try to look for the central fever compared to sepsis. But again, if we delay our antibiotic by every hour, as in this landmark trial by Dr. Kumar, that every hour delay in antibiotic increases mortality by 1.5%. And of course, which means that you have to find the source, you have to find the penetration of that tissue which is infected and give the antibiotic at appropriate time. So with that basic idea in mind, we go to our first case, who is a 65-year-old gentleman, a follow-up case of left MC infarction. Infarction with fever, with brief history of uprolling of eyeballs, we suspect that as a seizure. He is diabetic, hypertensive, and bedbound for last 3 years. His GCS in the emergency department was around E2, V2, M5 with right-sided hemiparesis, which is not new. And he also had a second-degree bed sore in sacral area. So if we get a case in the emergency department, there are multiple sources of sepsis in this patient, starting from aspiration pneumonia, there may be urinary tract infection, there may be infection from the sacral sore, because the patient is bedridden for many years and he is diabetic, and maybe other community-acquired infections and tropical infections also we have to need to think when we get a patient in the emergency. But again, a diabetic patient may have other infection which is specific to the central nervous system. So you have to differentiate between infection in the central nervous system from an infection outside the central nervous system, which is we call a septic encephalopathy. So he was initially supported with oxygen by nasal cannula, not so sick, supported with IV fluid initially, and we did the initial blood workup, which is not very suggestive of overt infection. Although CRP was mildly high, there was kind of rise in the creatinine from the baseline value, but more significantly, patient was hypoglycemic, which may happen in a diabetic patient who is infected for many causes. Subsequently, the blood glucose was supported with dextrose-containing fluid. And then we also actually worked up for the sepsis. So we did a blood lactate, which is the first 1 hour bundle in the new sepsis guideline, and then has to be corrected while going on the sepsis resuscitation. All the microbial cultures done, including the blood culture, which is the prime importance before starting any antimicrobial therapy. And all these things were done within 1 hour. So blood, urine sample, respiratory sample, and other wound swabs was taken. And then the patient was started with some look for other body fluid accumulation in other area. So now we need to decide whether we need to go for a lumbar puncture or the CT scan before the lumbar puncture. So let's see what the Infectious Disease Society of America says about it. So they actually define how to differentiate from primary CNS infection from septic encephalopathy with these parameters. Now, you can see these studies are difficult to do, and many of the time you have to judge for basically expert opinion for that, because many times patient may have developed the infection in the meninges before presenting to the ED. So timing of antibiotic and whether there is other things being done before coming to a tertiary hospital is very difficult to study. So we need to know very specifically whether we need to go for a CT head prior to lumbar puncture or not. So they come up with the guideline that in these patients, like immunocompromised patients and like HIV or other immunosuppressed patients with history of CNS disease which has mass lesion, whether the patient has new onset seizures, especially in adult patients, having a papillary edema, or there is abnormal level of consciousness from the baseline, or there is a new focal neurological deficit, especially in adult patients, we need to go for a CT scan before lumbar puncture, because otherwise there is only mild and 1.5 to 6% chance of basically herniation in these patients. So they come up with this flow diagram which says that in these patients, if there is either of these parameters, we need to go for a CT scan. Otherwise, we need to go blood culture and then lumbar puncture and then start empirical antibiotic as soon as possible. And then it helps in basically a diagnosis and following up with the proper antibiotic, because when you do a gram stain, which has a sensitivity of around 60 to 90%, with the first dose of antibiotic, the sensitivity goes down by around 20%. So you have to be very prompt in doing a lumbar puncture and then a prompt antibiotic. So in our patient, actually the routine CSF have very low cell count, which is lymphocyte, basically normal. Although the patient was hypoglycemic, the CSF glucose was not that low, and also the protein was not that low. And of course, the lactate was in the normal parameter. Again, in community-acquired bacterial meningitis, because of many reasons, the CSF lactate is not a good parameter to differentiate between bacterial versus non-bacterial meningitis, which is not like a nosocomial meningitis. Again, in gram stain, we found no organisms, which has a good sensitivity. We also tried to send a PCR, but as the gram stain was negative, PCR, of course, has a higher sensitivity to pick up infection, which is around 98% specificity and sensitivity. So in our case, in the first case, there was very difficult to get any community-acquired cause of infection. Cultures were sent and data was awaited in our case. So we discussed that which patient to undergo CT head prior to lumbar puncture. We discussed that what are the specific diagnostic checks like the routine tests, the gram stain, the lactate and PCR, which we have done, and what other laboratory parameters we need to do to differentiate bacterial from other meningitis we need to think of. And along that line, you have to think of the serum CRP and procalcitonin differentiate, but none of them give a clear marker which is the source of infection and which should be our appropriate antibiotic. But any case, whatever it is there, you have to start managing the patient promptly, whatever your suspicion of infection. And in community-acquired infection, usually the third generation cephalosporin plus minus vancomycin is the drug of choice to start with, which has been started after the bacterial cultures. And then when the cultures comes up, we have to think for a specific antimicrobial agent. But in our case, all the CSF gram stain was negative, and also the cultures were negative in time. But again, to reduce the CNS inflammation, the adjunctive dexamethasone has a controversial role. But when we think of CNS infection and the CSF routine parameters are abnormal and suggestive of infection, we usually start that dexamethasone along with the antimicrobial. So coming to our case, we also did the tropical infections for a malaria workup, dengue, scrap typhus, and typhoid IgM, and it was found to be Plasmodium falciparum positive. So in that case, we targeted with artemisinin IV for 5 days, and gradually the patient's sensorium improved, and we've ultimately got the patient in right track. Coming to the case 2, which is a 55-year-old lady who came with a headache, and there was a past history of CA breast with post-chemotherapy and undergoing on tamoxifen, and found to be admitted for a biopsy in the pituitary area. And she undergoes a pituitary biopsy, and a lumbar drain was placed. On post-operative day 1, she's suddenly becomes restless on very early morning, pulls out urinary catheter and nasal packs. So immediately for the drop in the sensorium, patient goes for a CT scan, which shows not much change from the initial CT scan, with some amount of hydrocephalus. Probably ultimately the patient has a pre-existing hydrocephalus to start with, not much increase in the blood around the perioperative area. So to reduce the hydrocephalus, patient undergoes particular drain, but again in the post-operative day 3, patients starts having fever. So how to deal with the case? So in this case particularly, the patient has many risk factors for post-neurosurgical meningitis. Patient underwent. Okay. So first of all, patient underwent a neurosurgery with a ventricular placement of drain.
Kindly mute yourselves, please.
These patients who are having different space-occupying lesions in the brain usually be on steroids, especially on pituitary surgery, and especially this patient has a surgery for the tumor, and there could be some amount of blood in the ventricular system, and there was a placement of the extraventricular drain. So all out of the all risk factors available, patient had some, and she had some risk of post-operative nosocomial meningitis. Now, if we see in the graph the number of days the EVD stays inside the brain, the chance of infection increase. All of us know. So how to reduce the risk? We have to follow the proper protocol of 5 measures, like always wear a proper gown, use a longer drape, always use gloves with hand hygiene, and of course a cap mask before handling the EVD, and reduce the frequency of handling the EVD. So otherwise, if you keep the EVD for more than 5 days, suddenly the chances of CNS infection goes higher and higher. Only prophylactic antibiotic can prevent some amount of infections, but that doesn't mean that if you keep the EVD for 7 days and continue the antibiotic for 7 days, there will be no infections. Only that increases the chance of colonization with resistant bacteria and chances of increasing the nosocomial meningitis post-drain placement. In this nosocomial meningitis, again, we need to think how to detect it. And IDSA comes with different clinical and biochemical parameters to detect it. They say that what are the typical symptoms and signs in patients with healthcare-associated ventriculitis? There may be new headache, some amount of altered mental status, although the presence or absence of fever doesn't make much difference. But if the patient has a shunt and there is subcutaneous shunt that has some amount of moderate evidence that it can be a new nosocomial infections. If the patient has any other kind of shunt like ventricular peritoneal shunt or ventricular pleural shunt, then symptoms and signs specific to the area like peritonitis or pleuritis may be a sign of nosocomial infection. So in that case, as we know, it is a post-operative case. The routine parameters like the cell count, glucose, and protein doesn't make much difference to isolate from infection versus non-infection. But in this case, the positive gram stain, the higher lactate more than 4 millimole per liter, definitely isolate patients with a nosocomial meningitis from a non-infectious cause. So that means if the patient is already on antibiotic, all the routine CSF parameters which isolate patients from non-infection to infections are difficult to guess. And only very few parameters like isolation of the bacterial organisms in the culture media or in the gram stain signifies that there could be a chance of infection. In this, the CSF culture are the most important test to establish diagnosing healthcare associated meningitis as per the IDSA, and it has a high significance. So we need to know if there is an infection, whether there is a contamination, which means there is only single culture positive without a CSF abnormality or clinical normality, or it's a multiple culture positive without CSF abnormality or clinical alteration, which we call it colonization, and whether it's infection, which means there is CSF abnormality along with clinical abnormality with culture positive. So you can understand that if there is a contamination, probably we don't have too much worry. But if you repeatedly contaminate the EBD, which stays longer, and it colonized with multi-drug resistant organism, and then it becomes an infection which is fatal for the patient. And in that case, we have to be prompt about the antibiotic, because by that time, the patient is colonized with multi-drug resistant organisms and is prone for longer duration of antibiotic therapy, ICU stay, and hospital stay. So what are the specific tests? As I said, we usually do the CSF lactate. We commonly don't do the CSF procalcitonin. But of course, if there is a high serum procalcitonin along with the high CSF lactate, he has very high sensitivity of 80% and specificity of 98% that the patient had a healthcare associated ventriculitis or meningitis. Again, if we want to rule out with the clinical and other biochemical parameters, we can go for a MRI guided gadolinium enhancement to look for the enhancement in the diffusion weighted images, along with whether there is a localized infection inside the CNS secondary to the intervention, whether there is an abscess form, because at that time, if we just give antibiotic and do not remove the abscess, it is very difficult to treat. And the infection cure rate decreases to up to 36% with longer duration of antibiotic. And in that case, we have to give a proper antibiotic, which includes anti-Pseudobacter lactam and many times basically carbapenems along with MRSA coverage or vancomycin to be our empiric therapy of choice. But most of the cases, we try to isolate a culture and then narrow down our antibiotic therapy. So once a pathogen has been identified, a specific antimicrobial has to be administered, but we need to know how long it should be given, because longer stay of different catheters, whether it's extraventricular drain or it's an internal drain like a ventricular peritoneal shunt, unless the shunt has been removed, the infection cannot be cured at all. So coming to the other localized therapy as per the IDSA, which is we can sometimes use interventricular antimicrobial therapy when there is a resistant infection to the systemic therapy. Different antibiotics like the polymyxins and colicins sometimes may be used, but still these recommendations are not FDA approved, and none of the antibiotic in our practice area are basically preservative free for use intraventricular drain through the interventricular drain. So use of them has to be very cautious approach, because that may cause inflammation inside the brain itself. So when you use it, even the chance, we have to use it in proper dose, which should be higher than the MIC, and then you have to clamp the EVD to keep the antibiotic circulate in around the infected area, and then hope that we do not have to use for long. As I said, none of the antibiotics till date are FDA approved for intrathecal use. Now, again, what should be the duration? And of course, in this, of course, there is not much study to say that how long to use it. We use basically different expert suggestions, and different antimicrobials for different specific bacteria has to be used for a longer duration, for at least 21 days, and look for a negative CSF culture to say that the infection is getting cured. And sometimes if the CSF culture is negative, then we continue for at least 10 days till the positive culture to say that it is treating the actual nosocomial meningitis. Now, again, if we keep the catheter inside, which is a source of infection, it may basically colonize with the multi-drug resistant infections. And as per the guideline, it has to be removed for proper cure of the infection. Monitor guided us that we have to do repeated CSF parameters investigations, and of course the cultures we usually take around 4-5 days to come. Even in fungal cultures will take longer to come, to say that the antibiotics is properly acting, and there is antimicrobial proof for that. And then when the patient requires some kind of shunt, in this patient, particularly in hydrocephalus, we sometimes change the extraventricular CSF parameters are normal, while there is culture negative. And in that case, when there is a staph aureus or gram-negative bacilli is there, which is difficult to treat, the new shunt can be placed only after 10 days from the negative culture. So our first choice, the patient went into the extraventricular drain, and in that case, only basically we say that peri-procedural prophylactic antibiotic is recommended to prevent shunt infection, and prolonged antimicrobial prophylaxis for the whole duration of the EVD is of uncertain benefit, and that only increase the colonization with multi-drug resistant organisms and chances of more resistant infection. So after dealing with 2 cases with basically CNS specific infections, we need to think about systemic infectious complications in individual acute critical care disease process. And in that, we go for first of all, the traumatic brain injury. As I said, that these patients require prolonged hospitalization, may require surgery, they may require like nasogastric tube, use of barbiturates, longer duration of intubation and mechanical ventilation. And of course, after the CNS surgery, because of the trauma, they have basically risk factors for CSF leaks also. And in these patients, the chances of hospital infections are very high. That is more than 40%. The most common is basically pneumonia or surgical site infections. So you need to find out the source of sepsis. When there is a basically infections in these patients, the mortality decreases from around with or without the VAP, it is from survival decreases to basically 46% compared to 69%. And even the infection in the early period increases the long-term outcome of these patients, and functional outcome worsens even after 5 years of injury. Similarly, in ischemic stroke, there is the patients may have like increases mortality in these patients secondary to pneumonia, which is up to 27% compared to patients without pneumonia, which has a mortality of around 4%. These patients has different risk factors for the stroke, and these risk factors may cause the patient more prone for different infections like dysphagia, maybe some alcohol consumption, COPD, or any pre-morbid illness like diabetes, which is a risk factor for stroke. Now, of course, the risk factors for hospital-acquired infections. Similarly, in subarachnoid hemorrhage, these patients require different neurological interventions like interventricular drains and all, and there is presence of interventricular blood, and these causes these patients for more chances of nosocomial infections. And patients with status epilepticus, who usually may get prolonged ventilation and other long-term ventilation because of control of the status, they may have some amount of ventilator-associated pneumonia. These infections are specific to the disease, and these causes our Neuro Icu more separated from other general ICU. Now, coming to our third case, which is from a different state, a 55-year-old police officer, probably working in different workplaces all the time. He presented with 2 weeks of fever, in low-grade fever in the local hospital. Initially empirically treated with antibiotic. He was diabetic. 1 week later, he had 1 episode of seizure. followed by new left-sided weakness, which was not there, and of course a drop in the sensorium, which was persistent. He was mechanically ventilated and airlifted to Kolkata. In his initial MRI found that there is a mass in the right side of the lobe, along with significant edema in the lesion. So initially planned for a biopsy, and it was found to be full of pus, and it was examined. The biopsy revealed that the wall of an abscess with central necrotic tissue surrounded by the inflammatory granulation tissue as the pathology reported, and it followed by a gram stain, which shows a gram-negative bacilli. And as patient was airlifted, more than 2 weeks of infections empirically started on carbapenem. The culture after 5 days revealed a Burkholderia pseudomyelii, and according to that, the carbapenem was continued for 6 weeks. So, of course, we know that usually carbapenem is not our first choice of antibiotic to start with, but of course, the Burkholderia pseudomyelii is now commonly increasing in numbers in different parts of the world, especially in Southeast Asia and Australia, of course, in India. The mortality is around reported around 9.5% in India, which is compared to very high percentage, around 40 to 50% in other South Asian studies. The patients who were basically immunosuppressed secondary to diabetes and in other suppression, the chances of infections are very high. And whenever it is detected in relatively early phase and treated with proper antibiotic, it can be treated. And CNS pseudomyelin infection is only reported in 1.5 to 5%. It may cause soft tissue infections, but CNS infection in cerebral abscess is very rare. It sometimes basically forms abscess from frontal to parietal lobes, and specific tissue diagnosis is needed for starting a proper antibiotic. So if you see that in normal community acquired pneumonia, when you suspect basically CNS infection, we start with probably ceftriaxone vancomycin, which is probably has some amount of in vitro activity against pseudomyelin, but probably not the in vivo activity. So choice of drugs in different studies differ from ceftazidime to carbapenem to doxycycline, especially in the consolidation phase. But first 6 to 8 weeks of carbapenem is the first choice nowadays in our scenario, and then followed by the other sensitive phase like the trimethoprim, sapamethoprim can be used in the eradication phase. Now, of course, other oral drugs like doxycycline if it is sensitive. But again, the proper diagnosis of the infection, the localization of the infection, and the culture sensitive tissue diagnosis is prime important to increase the survival in this infection. Going to the case 4, who is a 56-year-old gentleman, presented with gradually increasing headache for 30 days with low-grade temperature for 20 days as reported, along with multiple episodes of vomiting for last 7 days. So the condition was worsening, along with blurring of vision for 5 days and slurring of speech, but there was no history of convulsion. On examination, the patient had some amount of neck stiffness. He was not diabetic, but hypertensive on irregular medication. So we did an initial CT scan, which was normal. The initial lab parameters was not such supposedly for any infective parameters, and patient was apparently non-diabetic to present with. So in this case, we found also the CSF pictures, which shows a very high lactate with some amount of increase in the leukocyte number with increase in the protein. And there was yeast form of fungus on the routine analysis. So when we did the gram stain, it also showed basically Cryptococcus neoformans. So India ink stain was done, which shows the capsulated budding around yeast cell, suggestive of Cryptococcus neoformans. India ink stain is basically relatively sensitive when the fungal burden is higher, but sensitive goes down when the fungal burden is lower. And again, the CSF culture revealed there is fungal growth and there was no bacterial growth. So this fungal infection in this patient is also be suspected when you are dealing with a patient with fever, with altered sensorium, and basically features of nuchal rigidity. So in that case, you have to go for a proper culture and then antibiotic. In our case, we did also MRI, which shows some amount of meningeal enhancement without specific localization or abscess formation. But then we went for a culture-sensitive antibiotic and looked for causes of immunosuppression. In our case, although the patient had no obvious cause of immunosuppression, the patient was not diabetic, negative serology for HIV. She had some amount of low CD4 count, which is lower than normal, but we are yet to find out the cause of that. And we started on appropriate antibiotic. You can see the epidemiology of this cryptococcus infections, which is almost 1 million per year, causing more than 6 lakh deaths per year, and which is increasing from country to country as the diabetes is emerging as an epidemic throughout the world. So apart from bacterial infections, fungal infections, specifically CNS-directed fungal infection, has to be also looked for when you have to find the patients with fever, altered sensorium, or signs of meningeal irritation, and of course a neurological deficit. So we have to look for especially fungal infection when the patient is immunocompromised, when there is basically glucocorticoid use, history of malignancy, diabetes, which is very common, and now with increasing number of organ transplant recipients with immunosuppressant recipients, we have to look for specific fungal infections when there is CNS specific symptoms. So as per the 2010 update for the IDSA guideline, of course, there is lack of evidence for specific antibiotics, but till now, the choice of antibiotic in our scenario is liposomal amphotericin B for at least 2 weeks, along with fluconazole, because we don't have a flucytosine, and then followed by the consolidation phase with only fluconazole. So when you use liposomal amphotericin B, you have to look for the side effects of it, whether it's a renal tubular abnormality. We have to recheck all the electrolytes, like looking for hypokalemia and hypomagnesemia. It can cause thrombophlebitis and thrombosis in different blood vessels. So we have to look for all the side effects of the drug when you are dealing with the cryptococcal meningitis and treating with longer duration liposomal amphotericin B, and then followed by the side effects of the fluconazole or newer azoles like posaconazole. But again, you can see that when you are searching for a fungal infection in the central nervous system, the echinocandins, which is usually a choice in other fungal infections around the body, has low penetrability. So that is not the choice. Only options are the amphotericins and the azoles. So as per now, the patient is doing good. And then you have to look for other source of infection when the patient is longer staying in the ICU. Thank you. I'm open for questions.
So thank you, Nilanchal. Hello.
Yes, ma'am. Thank you, ma'am.
He has extensively, he just covered all the things, starting from what is sepsis, and then what are the factors which are very much important in neurocritical care when the patient goes for sepsis. So we are now open to questions, and I'll request Sovana to also have interaction on this. Dr. Shobana, please.
Thank you, madam. Am I audible? Hello?
Yeah, ma'am, you're audible. Yeah, ma'am.
Yeah, thank you. At the very first, I would like to thank this forum for having me here today, especially Bibu madam. And thank you, Nilanchal, for that extensive coverage of infections in neurocritical care. I find that there aren't any questions in the chat box. So I think I would like to share some um, more discussion part where we can discuss certain things like whenever we get a patient, obtunded patient in the critical care, neurocritical care unit, one of the differential diagnosis must be sepsis, because most of our patients are elderly with comorbidities, and they would not be mounting a fever. A febrile response does not come in the elderly. So if there is an elderly patient with obtundation or convulsions, then always think of a sepsis on a background of this. Other things which would be coming in the differential would be a status epilepticus or a stroke or a metabolic encephalopathy, of course, hyponatremia, etc., etc. But so always a sepsis should always be kept on mind, but then it is better not to jump and start off with very high-end antibiotics. If at all, if you have to start something, start with something which would cover the community acquired infections and then escalate as per your lab reports. I think I would do that. And in case of a young patient who comes with fever and plus minus neck rigidity, of course, we should always do a CSF analysis. But in young patients with fever, also we should keep in mind other causes of hyperthermia like drug overdose, etc., etc. So these would be just to keep the differential diagnosis in mind. Over here, we have found that those with a focal neurological deficit, for example, a stroke patient who has a left hemiparesis, sometimes people come and say they have become obtunded and the left side has become, or the right side has become more weaker. We always think that it is a fresh stroke. Over here, I would like to say that if there is any septic process going on or a metabolic process going on, then the focal deficits manifest more extensively. They become more manifest later on also, even if they have a prior deficits. Like a person with a hemiparesis of 4/5 sometimes would be coming with a left hemiparesis of 3/5 or 2/5 with on a background of sepsis without any acute neurological event. And of course, regarding, as Dr. Nilanchal has said, CRP and ProCal, they are quite sensitive in picking up, but whatever parameters, whether you want, whatever is available in your hospital, procalcitonin level measurements are costly. So even if it is CRP or procalcitonin, it is the trend of the parameter which is important. Whether the CRP remains high or it is going higher or going lower with your therapy, that needs to be tracked. So a single CRP of 60 does not have any meaning. Secondly, regarding the cases, Dr. Nilanchal has really picked up the different varieties of cases that we see every day in the ITU. So coming to the first case, over here, I would like to tell you that in case of any person coming with obtundation in a tropical country, always as a routine, like you send for hemoglobin TCGC, ESR platelet, always send the MP dual antigen and dengue, NS1 antigen and IgM, IgG along with it. Let it be a reflex of your pen, because otherwise most malarias are often missed, because most elderly people do not present with typical symptoms of fever, chill, and rigor, etc. That is why in tropical countries, it is very important to have that in the mind. Next, that is how we picked up in the first case, falciparum malaria, because on the very first day we had sent off with the MP dual antigen and the peripheral smear for malaria. And we were quick enough to, and this man had been bedbound with a bed sore and obtunded. He could have had seizures. He had a hypoglycemia. Hypoglycemia is another very common presentation of a malignant malaria. So these things have to be kept in mind. Also, in case of in tropical countries where you have, if a person comes with slightly deranged LFT, slightly deranged renal function test, always think of leptospirosis as well. Very, very common. Of course, in COVID era, elderly coming with only obtundation could be COVID. So these are the things which you must always keep in mind. And in case of elderly, the neck rigidity is sometimes not a very definite sign, because those with Parkinson's disease or stiff cervical spine, they may be stiff on the neck anyways, and it is better not try to flex the neck too hard and cause more injury. So that is why you must always be suspicious of an infection of CNS infection or a tropical infection in case of an elderly. Now coming to case 2, now this case, this lady with CA breast was obviously having a background of an immunosuppression, and she had an EVD in situ. From day 3 onwards, be very alert for infection in case of an if the EVD is in place, because as we all would want to have the EVD out as early as possible. It is not always possible to remove the EVD that early, because usually the patients take time, the hydrocephalus takes time to come down because the disease process has to come down. In case of nosocomial meningitis over here, in our hospital, we have seen more than 95% of the nosocomial meningitis are caused by gram-negative organisms like, sorry, most often Klebsiella, and more dangerous is the Acinetobacter, which are all MDR organisms. Sorry. So gram-positive organisms are in fact less, although we cover empirically with meropenem vancomycin, but often we find that when we do get the growth of organism, it's a gram-negative. So giving a good gram-negative coverage is important. Actually, in case of nosocomial meningitis or ventriculitis per se, the penetration of all these drugs are very low into the CSF, excepting meropenem. Colistin has very low penetrability into the CSF. That is why even though there is FDA has a lot of things to say about it, we do use intraventricular colistin with the available preparations which are in the market. There is no other way out. And how do you assess whether your colistin is working or not intraventricularly? It is better to redo the CSF, as Dr. Nilanchal said, say after 48 to 72 hours, to see how the picture changes. Because anything given intrathecally will induce a chemical meningitis as well. So we need to be really extra careful when we give intraventricular drugs, and with total asepsis and precautions. Very, very important. There should not be any CSF leak from the drain to the bag which collects the CSF. The two important parameters, three important parameters is clinically how your patient looks, whether the neurologically they have better sensorium. Number 2 is go by the CSF routine. Glucose will give you a good parameter of whether the infection is improving or not. And of course the lactate. And obviously you have to do it serially. So for nosocomial hospital acquired meningitis, ventriculitis, I think this is what comes to my mind now. Now coming to case 3, this fellow from Assam who came with a subacute chronic fever. People would jump to think of tuberculosis. That is the commonest diagnosis, of course, but not everything is tuberculosis. We need to, in this case, with that kind of an SOL on the right side of the brain, which is very easily accessible to surgery, a biopsy is a must. Always put your foot down and make the surgeon, convince the surgeon as well as the patient's family that we need a biopsy. Because a Burkholderia cannot be diagnosed by my MRI, nor can you just guess that this must be Burkholderia. Accepting that Burkholderia meningitis or encephalitis, when it does cause meningoencephalitis or encephalomyelitis, usually may affect the brainstem as well. That is one clue that it could be Burkholderia. But this man had just a right parietotemporal abscess. That's all. So until and unless a biopsy is done, we would never have reached a diagnosis, and he would have been killed by giving ATD. Now, for Burkholderia, once the diagnosis is there, you can very well treat the patient very nicely. In case of patients who are in the ITU with obtundation, ventilated, etc., drug of choice would be a carbapenem, meropenem, at least for 6 to 8 weeks. This man's Burkholderia was resistant to trimethoprim sulfamethoxazole. That is why we could not add it. Otherwise, you get the IV preparation of trimethoprim sulfamethoxazole these days, and with very good, even the oral drug has very good penetration into the CSF. So this man, we could not treat him with trimethoprim. So that is why we had to stick to meropenem. And later on, you need to give a maintenance drug, and that would be tetracycline group, doxy, or a minocycline for this man. So, and coming to the last case, which is cryptomeningitis. Now, how would you think that this is something else? Now, this man is 56-year-old with no known comorbidity as such. Somewhat subacute to chronic symptoms. Cryptomeningitis sometimes presents only with headache and no fever. Sometimes no neck rigidity. It's very, very difficult to jump and say, oh, this must be cryptomeningitis. You never can do it. The telltale signs over here are 16 cells. It could be anything viral, anything fungal, even tuberculosis. Glucose is very low, goes against most viruses, right? Excepting mumps and probably one or two other viruses, glucose doesn't go so low. Again, glucose may be low in case of tuberculosis. Cells are not high. Protein is just 88. Again, tuberculosis protein is usually very high. Even in cryptomeningitis, it is usually higher than this, but this 88 is fair enough. Lactate was very high, but usually we do not do routine lactate in case of a community-acquired meningitis. So this man has meningitis. What must be done in case of any suspected meningitis? The moment you put your needle into the CSF space, please measure the opening CSF pressure. Very important. This man's CSF pressure must have been very high. Cryptomeningitis is diagnostic when the CSF pressure is very high, around say 100 or 150. That means it is nothing but crypto. Most of the cases, especially in the HIV infected individuals. Why I am stressing about opening pressure in cryptomeningitis is that has got a lot of implication on prognosticating, because a very high CSF opening pressure would lead to a very high mortality and poor outcome in cryptomeningitis. Next is routinely, whenever you are thinking of meningitic or encephalitic process, send the routine first and keep 2 or 3 samples always in hand. Of course, for microbiology, if you refrigerate the sample, it doesn't harm. But if in case of routine CSF protein and cells and sugar, If you refrigerate the sample, you lose the cells and it would give to rise to erroneous results. So we preserve the CSF only for microbiological analysis. The moment you get this kind of a leukocytosis, a reactive CSF, always send everything. Do not wait for the next day. Send a gram stain culture, AFB stain culture, fungal smear culture, India ink preparation, MTB gene expert RIF in case of this patient, definitely. Very important is you must always send a cryptococcal antigen, because Cryptococcus, finding it under the microscope or not, if your microbiology lab is not strong enough, they may miss if the number of yeast cells are low. But the antigen is very sensitive and specific, and so you will easily pick up. Getting a crypto antigen titer is equally important, just to know the extent of the load of the organism, but it does not have any prognostication by doing it repeatedly, like therapeutically, whether you are on the correct track or not. You cannot do it by doing a routine, serial crypto antigen titer. It doesn't help. But definitely prognostication, higher the titer means your fungal load is high. Simultaneously, you may send a blood or serum cryptococcal antigen assay that is even more sensitive to pick up, because I have seen patients who have come obtunded, who have never had India ink positive, and we picked up crypto meningitis by a positive serum crypto antigen assay. So, and that patients responded dramatically to liposomal amphotericin B and flucytosine. So very important, managing crypto meningitis is a real challenge, because patients become suddenly obtunded, they would blow out their ventricles, they have sudden hydrocephalus and coning, and they die. And we have lost patients like that. Or they may have a vasculitic stroke. So, and in case of a very high CSF pressure, what you must do is a serial therapeutic lumbar puncture to drain the CSF around 40 ml every 72 hours. That gets rid of the increased intracranial pressure and the organisms as well, because the crypto capsule of the organism goes and blocks the blood vessels and the CSF exit points. That's how the ICP rises in crypto meningitis. So doing a therapeutic lumbar drain is very important. Over here, mannitol does not work. Dexamethasone is contraindicated.
Dr. Shobana, you have muted yourself. Dr. Shobana, we are not able to hear you. You have muted yourself. Kindly unmute.
Yes, Dr. Shobana, please unmute yourself.
Disease or rheumatoid arthritis. Otherwise, sorry.
So now?
Can you hear me now?
Yeah,
Yes.
yeah, Dr. Shobana.
Yes.
So, as I said, steroids are contraindicated in cryptomeningitis until and unless there is some other pressing reason to give steroids, like rheumatoid arthritis or whatever. And the CD4 count was low in this case, but let me tell you that CD4 counts are routinely low in case of tuberculosis and cryptococcal meningitis, because all these are very immunosuppressing diseases. So CD4 would not have a real, it would not mean anything until and unless there is an HIV positive, right? Another thing about meningitis, treating meningitis is in community acquired meningitis, please do give the steroid as early as possible. Even if you are suspecting and you have not even done a lumbar puncture, start the steroid and the antibiotic, please. You can do the lumbar puncture even after 24 hours, starting the steroid and antibiotic, because otherwise your that leads to a lot of inflammation and leads to focal deficits, hearing loss in children, etc. So this is a very, very important point in community acquired meningitis. starting steroids and antibiotics. In cryptomeningitis, let me tell you that we nowadays are finding more and more normal people, no immunosuppression, no reason for an immunocompromise getting cryptomeningitis, and usually these are usually cryptogattii infections. So they are quite common in the normal hosts as well. So the treatment of cryptomeningitis, of course, liposomal amphotericin B and flucytosine. Long term, we have given antifungals for even 6 weeks duration. Very costly and with side effects. And as Dr. Nilanchal said, you need to look for the dyselectrolytemias. Flucytosine can also cause cardiotoxicity. So there can be a sudden cardiac arrest even, especially on a background of a electrolyte imbalance. So we need to keep all this in mind. Of course, you follow up with the maintenance fluconazole. Nowadays, especially in African countries, since cost is a big issue in and availability is a big issue of liposomal and amphotericin B, they have had trials giving oral flucytosine and fluconazole combination for those who can take orally, and that has had a good effect. So that came out in the New England Journal a few years ago. That is one option maybe. So although we have not tried like that in our patients, we always stick to amphotericin B. Sometimes if the patient cannot afford, I have also given the deoxycholate amphotericin, which is quite affordable by everybody. So I think these are the things which I thought need to be highlighted. Otherwise, the rest of it is all Dr. Nilanchal has already covered. Madam?
Yes. Thank you, Shobna, for highlighting certain points which are very important. And now, any question there? Any interaction from seniors who are there? And any question from the students and in the chat box? Any question there?
Ma'am, there are no questions in the chat box. Any comments from anybody? Dr. Pragati, ma'am? Pragati, ma'am, are you with us?
Yeah, hi. I'm very much here.
Yeah.
Moving around. Yeah, sorry. I was talking to my son actually. Yeah. So this was very interesting, ma'am, Vibhu ma'am. And especially especially the commentary in the end, the summary of everything was very informative. I must admit I'm very dumb in critical care, but little things you learn, so that is why it's very nicely done, and especially towards the end what we summarize. So you are yeah, that was very good. Thank you so much. Thanks a lot.
So
thank you. Is Dr. Monterio there?
Dr. Zulfikar, Dr. Saurabh here.
Yeah, Dr. Saurabh, yeah, welcome.
Yeah, hi. So one or two things more which I want to bring to the kind notice in the meningitis era, which we are living in. Acinetobacter pseudomeningitis is also common right now. I have seen 2 or 3 cases of Acinetobacter pseudomeningitis in which Acinetobacter was a contaminant and not actually the Acinetobacter meningitis was there. There was no clinical sign and symptom of the patient's and the patient doesn't have any fever, patient is not showing any kind of depressed unconsciousness, no neck rigidity, nothing was there. And the CSF routine was showing some abnormalities, a borderline glucose, something like that. Because as a post-operative case, so nosocomial meningitis is very difficult to detect in a routine CSF examination. We send an Acinetobacter, we send a CSF culture and it showed Acinetobacter. We started treating patient for an Acinetobacter meningitis, but simultaneously we were suspecting that it might be a problem with the lab. We send another sample and that sample comes out to be negative. Without starting the antibiotics, we have sent another sample, and that sample comes out to be negative. To be on a surer side, we send a third sample as well. That sample also comes out to be negative. So then we come out with the literature, we searched for that, and it comes out to be in Acinetobacter pseudomeningitis, which is common nowadays in an ICU. So this is one thing which I want to bring a kind notice. Another thing is, those ciprofloxacin, fluoroquinolones, we don't use in neuro ICUs very frequently with the fear of seizures. But for Acinetobacter meningitis, fluoroquinolones have regenerated the interest in Acinetobacter meningitis, especially in which other choices we are not able to give, like in MDR Acinetobacter, which is now common with colistin and polymyxin resistance as well. And to choose from polymyxin and colistin, we generally go with polymyxin because colistin is generally a prodrug. So we generally want the drugs to act fast. So generally we use polymyxin rather than for colistin in these kind of drugs. So that's just a short comments from my side. Thank you.
Thank you, Dr.
Thank
Saurabh.
you, Saurabh.
Dr. Shobana, I would just some clarification. Sometimes in our neurosurgical setup, in the post-operative period, we get some patients with aseptic meningitis.
Right.
And then it becomes a very confusing picture as how to differentiate once we have a patient who is having a high fever, maybe at times neck rigidity, because many patients have neck rigidity because of the subarachnoid aneurysm, subarachnoid hemorrhage itself.
Right.
And once we go for CSF analysis in such patients, we do get because of the blood within the subarachnoid spaces, we do get a cell count, high cell count, even low glucose and high protein. So in these scenarios, we go for a cell index. We see the
Right.
cell index in the CSF and in the blood. And
Right.
what we presume is greater than 5 points out to be a bacterial meningitis. How far do you see? How far do you see the accuracy of this cell index in your clinical practice? Do you really find it reliable in your clinical practice?
We do ask for it from the lab, and often it is, the patients are already on antibiotic. They are already started on antibiotic because just not to miss hospital acquired infection. So then it becomes very difficult because after that coming to a conclusion, most of these people end up getting an antibiotic for at least 5 days before we really decide that this has got nothing to do with infection, and it's just a reactive chemical meningitis. So it's difficult. I think in these cases, sometimes use of antibiotic becomes a little more than what it should be, actually. Another thing over here I would like to comment is that the molecular genetics for CSF microorganisms these days, we are sending the BioFire for for hospital acquired infection with no use, because the organisms which they have included does not include the hospital acquired ones.
Yeah, ma'am.
Sending this for the for community acquired, it's okay, but for hospital acquired infections, I think it's a big waste of money to send it for PCR.
Yeah, definitely.
So that is why I think we could save money if we stop sending it and just go by the lab gram stain and cultures routine.
Another thing is, can I add something here?
Dr. Zulfikar, as regards chemical meningitis, Dr. Zulfikar, as regards chemical meningitis, the most important first thing is why you are going for a CSF test. So if you are suspecting meningitis in a patient, that means the patient must be showing signs and symptoms of meningitis first. Second, whenever you are sending a patient, post-operative patient for a CSF lactate will definitely help in differentiating from a chemical meningitis. But yes, sometimes it is raised as well. And the third point is definitely a culture. We generally wait for a culture because in post-operative patients, we generally stop after the third dose of antibiotics. We generally don't give antibiotics beyond 24 hours in our patients. So if CSF culture is also negative, till that time, we generally like to err on the side of caution, and we generally give our patients antibiotics. But after that culture, we generally stop giving antibiotics.
Zulfikar,
Yeah, ma'am.
can I say something here?
Sure, ma'am. Sure, ma'am.
And the background also, you have to have the background, what operation had been done and what is the diagnosis, like epidermoids. Sometimes these patients, if it is either it is epidermoid in the posterior fossa, that is CP angle epidermoid, or epidermoid or the dermoid, in those cases, you can have chemical meningitis. So
What
the
was
history,
my point with Dr. Shobna is really once we have a patient with aseptic meningitis and it's a gray zone. It's one of the tricky areas in neurocritical care where we are really
Absolutely.
confused
right?
as whether
Absolutely.
there's an infectious cause or aseptic cause. We do not have any definitive test. And the only definitive test that has come is the cell
Right.
index. And what I wanted to inquire in clinical practice, how often do we find this cell index informative once we try to differentiate aseptic from aseptic meningitis? Otherwise, as of now, we do not have any ways or means to differentiate
Right.
between the two. That was my main concern.
Okay.
Any questions
So-
from any of our students? Yeah, Dr. Ankur, you want to say something?
Yeah. Good evening, sir. Good evening, ma'am, and a very nice presentation and discussion. I would just like to mention that whenever we receive any patient who is suspected to be bacterial meningitis, so prior to start of antibiotics, we have our own protocol that we definitely start administering dexamethasone, and that is what the recommendation says, that dexamethasone has to be started prior to the administration of first dose of antibiotic, or at least with the first dose of antibiotic. So if we suspect it to be bacterial meningitis, and then when we confirm it by CSF analysis, we give dexamethasone 0.15 milligram per kg 6 hourly for 4 days as per the recommendations. And if it is tubercular, then definitely it has to go for a longer period, sometimes 4 weeks, sometimes 6 weeks. And second point is we never do a CSF analysis before doing a CT scan of brain. But particularly when we suspect raised ICP, we have to first rule out any space occupying lesion by a CT scan of brain, and then go for a CSF analysis. We never do a CSF analysis before doing a CT scan of brain. It should not be done. That is what the recommendation also
That's
says.
what Dr. Nilanchal already said, that you have to go for a CT scan primarily before going for CSF.
Yes, ma'am. Correct.
Dr. Shobna, Dr. Nilanchal, if you can take, there's one question in the chat box. What is the strategy if we have a patient whose cultures are positive, but the patient is asymptomatic clinically, and his laboratory wise asymptomatic? Probably the counts and other parameters, they are normal.
I think the question is, the culture is from tracheal side. That's what they mean, or
Especially
actually we were
those
talking about
long-term
CSF and
patients.
other things. That's why.
Dr. Dr. Chidananda, please, sir, can you just, are you, sir, with us?
Yeah.
Can you,
Can
can you clarify?
Yeah. Yes, basically for those long-term patients who are on tracheostomy in the ICU, where the tracheal cultures remain positive, sometimes we see they continue to persist to have the Acetobacter, Pseudomonas, Klebsiella. It keeps changing. But clinically, they're asymptomatic, no fever or signs of sepsis. white cell counts are normal. Even the CRP, Procal, everything is within normal range. So how do we go about? What is your recommendation?
If in an asymptomatic patient, no chest infiltrate, normal saturations, sensorium remaining the same, TC, WBC, CRP, everything remaining the same, you should not treat the lab reports. I think everybody would do that, not to treat the lab reports only. Of course, sending a culture, you at least know what organism is there harboring, colonizing the device. So that is for your information only. So in case this person develops a sepsis in the next few days, you know that this could be the organism, causative organism for the sepsis. So then you can your first choice of antibiotic would be directed towards keeping the organism, keeping in mind that culture report. Of course.
How often do you recommend replacing the tracheostomy or this thing like these devices? Because some of these long-term patients, they need a tracheostomy which gets colonized, and whatever antibiotics you give, it does not act because it's on the plastic surface.
No, yeah, for colonization and biofilms, it is not recommended that you give antibiotics because that will lead to
replace the device.
We do apart from the usual, blocks and other things, and physically getting if the device gets soiled and all that. Of course, beyond that, we do replace it routinely every 10 days or 15 days, as per individual patient basis.
Okay, thank you.
Dr. Bibu Kalyani, ma'am, can we just close today's talk?
Yes. If there is no question, so the discussion is over, so you can close the session.
Yeah. Thank you, Bibu ma'am.
Dr. Shobna.
And your
Thank
team.
you.
Thank you very much.
Thank you.
Thank
Good night.
Good night. Good night, everyone.
everybody. Thank you, everybody.